My name is Marsh. I did my graduate studies in pharmaceutical chemistry at the University of Kansas. I joined pharmaceutical industry directly out of grad school and have worked for Abbott/AbbVie the rest of my professional life. This small disclosure says that I work for AbbVie. It's required to be on my slides, so I made it as small as I possibly could. What I'd like to do today is talk to you about pharmacokinetics and ADME, build on several of the points that both Jims have brought up in their previous presentation. But what I'd like to show you is what you can learn from a pharmacokinetic study and how you can use it to ask questions for the optimization of your compound without necessarily understanding all of the equations that go into pharmacokinetic parameter calculations. So as was introduced in the previous session, we talk about hits, leads, and candidates. And as you move from a large number of hits to a lesser number of leads and a even smaller number of candidates, there are different assays that you can do from a drug metabolism and pharmacokinetic point of view, building on similar profiles that Jim explained. Pick assays early that you might want to run on hundreds of compounds that don't need very much compound at all. Small amounts of compound, high throughput assays to help you understand things like solubility, metabolic stability, as was mentioned before, in both a rodent species that you might be using for an in vivo assay as well as human, because we are in the business of developing drugs for humans. Permeability and efflux have been mentioned also, CYP inhibition, and maybe run pharmacokinetics on a couple compounds to just ask the question initially, is the metabolic stability that you're seeing in vitro, is it predictive of what you're going to see in vivo? Maybe you look at some target tissue concentrations also to give you a feeling for, is your compound getting to the tissue that you wish it to get to, like the brain? As we winnow down the number of compounds and work on lead compounds, and maybe that's in the 10s or 20s, then we'll start to look at things that take longer time to do, assays, things that will need larger amounts of compound, and things that will expand our knowledge of the compound so that we can start thinking about, if this compound went into development, what are some of the questions that we're going to have to answer? Like, what's the clearance going to be in other species other than the one rodent that you had and humans? We have to do tox in a rodent and a non-rodent species, for example. Let's understand some additional species and how the pharmacokinetics behaves there. We want to understand how the compound might be metabolized and what those metabolites are. We need to understand how the compound is being metabolized, which cytochrome P450 is doing the metabolism. Brain and plasma binding was mentioned before, and then we'll start to look at additional PK studies. As I mentioned, they might take longer periods of time. So let's look at receptor occupancy. Let's look at efficacy. Let's look at dose responses. Maybe start to look at, do I have the right formulation? Is the reason I don't have any efficacy because really nothing is getting into the animal? And then when we have candidate compounds, it's just a further refinement of what you have been exploring on your leads, but again, with an even further look toward, how is this compound going to behave in humans? And what do we need to do to convince, well, in my case, to convince upper management that they'd like to invest $10 million into putting it into men? And so in this case, for example, we'll do the pharmacokinetics in multiple species. This will help us with human predictions. We'll start to understand in a higher level of detail the PK/PD response. What dose are we going to need in humans, and what kind of response are we expecting from that dose? And all of these things will go toward putting together a package that will help you have a higher probability that your compound will succeed once you get it into the clinic. So I'm going to talk a lot about just pharmacokinetics. And from pharmacokinetic studies, We can define bioavailability. We can define the volumes of distribution. We can define clearance. And these are going to give you an assessment of what is described as ADME properties: absorption, distribution, metabolism, and excretion of your compound. Running a PK study will start to tell you about all of these properties. I mean, absorption is going to be a function of the bioavailability that you see. Distribution will be reflected in the volume of distribution number, et cetera, et cetera. So the question is, what can we learn from a simple PK study without knowing everything about a compound? One of the things that Jim mentioned is to run a microsomal stability on your compounds, and I noted that it's useful initially to look to see what the correlation is between the in vitro microsomal stability and the in vivo clearance. If you have a nice correlation like this, then you can screen and do the SAR in your compounds just using the in vitro assay, checking every once in a while that as you optimize your SAR, you haven't deviated from this line. But it allows you then to screen more compounds faster without having to depend on having a pharmacokinetic measure. But keep checking. But the other question that this brings up is, when you make this correlation, if there isn't a nice line like this, then what is going on? Maybe you don't have simple microsomal stability contributing to the clearance of your compound, and do you need to understand that more as you're trying to optimize the SAR? So let's talk about pharmacokinetics. And most of what I'd like to talk about today is related to small molecules. So for small molecules, many of them are going to be given orally, where they pass through the intestine. You hope that they dissolve and are absorbed through the intestine, through the liver, and make it into systemic circulation. If they're not absorbed or they don't dissolve, they're just going to end up eliminated from the body. But between dosing the tablet or the capsule and making it into systemic circulation, there are several barriers where the compound is metabolized before it actually gets to the plasma. And then once it's in the plasma, it will be distributed and eliminated. It's the concentration time curve that is measured after dosing that is what we define as pharmacokinetics. So pharmacokinetics is involved in a lot of different things. Obviously, the thing that you think about first is efficacy and the response to the efficacy. But we also have to think about the side effects and the toxicity. That's also going to be defined by the pharmacokinetics. The dose, the amount of compound that you need to get the desired pharmacological response. How often do you have to dose? Ideally, you'd like to dose once a day, but maybe your compound is cleared too rapidly and you have to dose 2 or 3 times a day. And then as we move toward development, we also want to take into account how easy is it going to be to make the compound. This is a lesser, weighted to a lesser degree in this collection of items, but nonetheless it's something to think about if you have 2 compounds that are exactly the same, but one is 10 times easier to make than the other, for example. And so what we'd like to do as we think about pharmacokinetics is obviously maximize the efficacy, minimize the toxicity, make the dose as small as possible. There's other reasons that it's nice to have a small dose. Gives you a smaller tablet. We'd like to have a dosing frequency that's easy for people to remember. People seem to remember to be able to dose once a day more easily than twice a day, or 3 times a day is very hard. In pharmacokinetics, there's a lot of abbreviations. And many of them, as we start off here, relate to the route of dosing. And the route of dosing is going to give you a different pharmacokinetic profile. So if a compound is given intravenously, directly into the brain, into the vein, you have very high initial concentrations that distribute over time. A compound given orally, most of the time, has lower peak concentrations. But then there are many, many other different routes of administration. And I raise this because the different routes of administration can give you different pharmacokinetic profiles. So make sure you understand the pharmacokinetic profile that you have and how it might be affecting the pharmacology that you're seeing or the tox that you're seeing. As we move into defining pharmacokinetics, you'll hear people talk about Cmax, peak plasma concentration. Peak concentration is very easily read directly from the concentration time profile, just by extrapolating over to the y-axis. Note that this is a log scale, so this peak concentration is about 33 micrograms per mil. Tmax is another pharmacokinetic property that you'll hear discussed. Tmax is the time to peak concentration. And the Tmax is nothing more than just extrapolating the Cmax concentration down to the x-axis, where it says the Tmax for this compound is about 2 hours. Knowing the Tmax also is useful as you start to look at the response of your compound. Do you have a Tmax at 2 hours, but your efficacy is at 6 hours? Well, then that's a question you might want to start asking. Is it really the parent compound that you dosed? Or is it a metabolite, maybe, that's giving you the response? So start to think about the correlation between when you're seeing the peak concentrations and when you're seeing your efficacy or tox. This is just an example that I pulled from a publication where I looked at the mean and looked at the Cmax from the mean, which is about 1.7 micrograms per mil, but in the paper it was reported as 2.1 was the Cmax. So the question on the table is, well, why do these not match? And what can you learn from looking at something where there's this apparent discord? To me, what this says is that there's a lot of variability in the animals, and there's a lot of variability in the rate of absorption across the animals. So that as you look at the Tmax values, they range from 1 to 6 hours after dosing. If this compound had been absorbed reproducibly in all the animals, then this extrapolated Cmax value would match this. So it's a quick, easy way to look at data that's being presented to you and say, okay, does this make sense, or is there something else that I can learn from just interpreting what's being provided? So why do I care about Cmax and Tmax? And I mentioned earlier, does your efficacy match with the Cmax? So suppose you're running a series of compounds, and in this collection, you have 2 compounds that have very similar in vitro potency against the target that you're screening for. You put them in an efficacy assay, one is active and the other isn't. It usually means that there's something different in the PK profile. In this case, compound B doesn't give concentrations high enough to exceed the IC50, so you probably won't see any efficacy. Compound A, on the other hand, does have concentrations higher than your target concentration. There'll be a higher probability that you'll see efficacy. You could say, okay, but I could just dose more of compound B. That's true. But Jim said make the dose as low as possible, because the higher you go in dose, the higher the probability is that you're going to introduce some sort of off-target or tox effects. So in this case, you would walk away saying, okay, compound A is better than compound B, based purely on its pharmacokinetics, or maybe other things too. What if I have a third compound, compound C, which is substantially more potent? Is compound C, which has a pharmacokinetic profile that is providing concentrations way over the IC50 for a similar period of time than compound A, is compound C better than compound A? I think we don't know the answer to that, but it's an interesting point that you theoretically would have higher exposure, but the higher exposure also could introduce more toxicity. over, for this compound that has concentrations so far above the IC50. So think about how all these things integrate together. Yeah?
I have a quick question. When you just glance at this and you say compound C clearly has much greater potency, where do you see that? Or how do you know?
So the IC50 here for compound C is this line.
Okay, okay.
So I'm drawing the IC50 as a target for where we want the concentrations to be.
Gotcha.
Okay?
Thank you.
Let's talk about a few more pharmacokinetic parameters that you'll hear discussed. One is half-life, or T1 half. The half-life is the time that it takes concentrations to decline by half. It's really that simple. And the half-life is determined from the terminal elimination phase. So when you have a log plot like this, the half-life will be assessed out here in the terminal phase of the concentration time curve. And you can actually estimate the half-life just from having a graph like this. You can pick a time point in the terminal phase. The concentration here is about 2 nanograms per mil. We can pick a second point where the concentrations have declined by half. So extrapolate to 1 nanogram per mil and then drop to the x-axis. This difference is the half-life. So this compound has a half-life of about 2.5 hours. You can do this from any set of data that you've been shown without being provided any of the raw data. So you can start to get a feeling for how the compounds are behaving just by looking at the graphs and doing a little bit of extrapolation. Half-life is different across species. Jim mentioned mice and rats chew up things very fast. That's true. You can see that a short half-life in a rat is defined as a smaller number than a short half-life in men. And this relates to differences in clearance rates across species. So as you hear people talking about short, medium, and long, make sure you understand what species they may be talking about so that you can get a good feeling for what the numbers actually are that they're talking about. So here are two graphs. Which compound has the longer half-life? Who votes for A? Who votes for B? Who thinks that I'm giving this as a trick question? All the faculty, they all know the answer. This is indeed a trick question. These are the same sets of data provided to you on a linear scale or a log scale. So the point is here to look at the data as it's being presented to you, and then make sure that you understand how it's being presented before you answer the question. A couple more parameters that you'll hear discussed in pharmacokinetics. One is area under the curve, and it's simply nothing more than a calculation of the area under the concentration time curve. You will see area under the curves reported in different ways. This might be area under the curve 0 to T. T might be the last sample that you took in that pharmacokinetic study. T might also be the last concentration that could be measured in that pharmacokinetic study. You might also see this reported as area under the curve 0 to 24 hours, because that's the interval that the area under the curve was measured. You'll also see people discuss area under the curve 0 to infinity, which might be with the infinity symbol or INF. This is actually a calculated parameter where you can take the last measured concentration, you can take the slope, the beta elimination phase slope, take the ratio, add it to 0 to T, and get area under the curve 0 to infinity. Why do I care about AUC 0 to infinity? AUC 0 to infinity is actually going to be the steady state AUC after multiple dosing. So if you dose once a day, then once you get to steady state, the area under the curve that you'll have will be equivalent to the area under the curve 0 to infinity that you might calculate from a single dose. So if you have an AUC target, this helps you understand from just a single dose pharmacokinetic study what you might have later with repeat dosing. What else do we use area under the curve for? Area under the curve is what's used to calculate bioavailability. Bioavailability will be abbreviated as F. F is the fraction of the dose that makes it into systemic circulation. And bioavailability is calculated using the area under the curve from an IV dose as 100% bioavailability. So what you're asking is what fraction of the oral dose compared to the IV made it into systemic circulation. In this case, when you look at this area under the curve compared to this area under the curve, the bioavailability is about 30%. So what's the bioavailability of this compound? Same data. This bioavailability is about 30% also. It's the same graph as on the previous slide, just now shown in a log scale. So what does high bioavailability look like? This is an example where the bioavailability is essentially 100%. If these two doses are the same, so they were both, say, 1 milligram per kilogram, then the IV and oral curves would overlap. So I'm not going to go into a great, yeah, sorry, go ahead.
You might have said this, sorry. Is the bioavailability denominator always for the IV administration? Okay.
Yeah. You can calculate a relative bioavailability if you wanted to calculate it versus a sub-Q, for example, oral versus sub-Q or something like that. But bioavailability is by definition versus an IV. I don't want to go into a great deal of detail on this. Many of these topics were covered by Jim in the previous discussion. But these are the many, many parameters that can have an impact on oral bioavailability. Lipinski's rule of 5, polar surface area, molecular weight, solubility, permeability. The reason I put these all here is that as you're optimizing SAR, if you said, okay, I need to make my molecular weight lower, whenever you change one of these parameters, it's going to impact another of them. And so you need to pay attention to not optimizing just one thing. Look at how they're all interacting together and how they are then impacting your bioavailability, for example. So you could make the molecular weight higher. That would probably give you a higher log P. It also probably would decrease your solubility, depending on what you did to the molecule. So just think about how all these things integrate together. But then as you move on from SAR and compound optimization, remember that things like formulation can affect bioavailability, food can affect bioavailability, age, diet, gender, all sorts of things can affect bioavailability. Maybe not so much in rats as you're starting your studies, but as we think about clinical development, these are all those things that we have to pay attention to. Okay, another question. Which is the best compound? And these are not the same. That's the question. Okay. So here are two compounds. Compound A has a slightly longer half-life, slightly higher peak concentrations, slightly lower bioavailability, but there are very large differences in the volume of distribution. So if you stepped on a nail and got an infection in your foot, which of these two compounds would be the best compound with the higher probability of curing that infection?
I want it to go to my foot, so I want it to be in the blood and circulating, not sequestered somewhere random.
No. You want it to be distributed to the tissues so that it can get to the site of infection. Yes. So you want a larger volume of distribution. Yeah. So this is B. This is kind of a trick question because I asked you this question and didn't tell you what the target was. And so when you're looking at pharmacokinetic data, know where you want the compound to be. If you have a target that's in the bloodstream, then you'd like a compound that has a low volume of distribution. No distribution to the tissues, lesser probability of tissue-related tox. If you have a target that you need tissue distribution, and for neuroscience compounds, we need tissue distribution because we need it to get to the brain, then you would like your compound to look more like B. But my point is, know where you need the compound to be. Understand your target, and then you can better interpret the pharmacokinetic data that's been presented. So what is volume of distribution, and how is it determined? Volume of distribution is just a term that relates the plasma concentration to the amount of the drug that's in the body. And it is primarily determined by the physical chemical properties of a compound. So log P, again here as we bring back log P, the pKa of the compound, the protein binding, receptor binding. Volume of distribution at a high level is divided into 3 buckets. Low volume of distribution, moderate and high. These buckets are the same across animals and into humans. So a definition of a low volume of distribution compound in a rat is the same as a low volume of distribution compound in humans. Compounds with low volumes of distribution tend to be polar, tend to be charged, are often proteins, so monoclonal antibodies. They are often renally eliminated. Some examples of low volume of distribution compounds are here. Compounds with moderate volumes of distribution tend to be a little bit more lipophilic, tend to be neutral, and have more intercellular penetration than compounds with low volumes of distribution. Compounds with high volumes of distribution tend to be more lipophilic and have a higher probability of having brain distribution. It's not a given, but if you have a higher volume of distribution, the probability improves that you'll actually get drug into the brain. You'll see many different measures of volume of distribution depending on who's doing the pharmacokinetic interpretation. Here's just 3, and there's more than this. VC, or volume of the central compartment, is actually calculated based on initial concentrations after the IV dose. V beta, the volume of distribution of the terminal compartment, is calculated more from the half-life of a compound. VSS is the volume of distribution at steady state. This is the one we tend to pay the most attention to, primarily for the reason that that's the volume of distribution at steady state, so we know what's going to happen after repeat dosing. Here's just another example of, is the compound in the place where you want it to be for the pharmacology that you're targeting? Here's 2 compounds. One is a quinolone antibiotic. One is an H3 antagonist that had a CNS target. They have similar half-lives, but very different volumes of distribution. The H3 antagonist has higher brain concentrations compared to plasma versus the quinolone. That's probably good. We don't need the quinolone antibiotic to be in the brain. But the quinolone antibiotic has very high concentrations in the lung, which makes it good for treating things like pneumonia. One last pharmacokinetic parameter to talk about, and this is clearance. Clearance is the rate that the compound is cleared as a function of time. And we use clearance values to compare to the rate of blood flow to a particular organ. So plasma clearance values are most commonly compared to liver blood flow to the liver, the rate of liver blood flow to the liver. And it will help you understand what's the probability that you actually are going to get compound into systemic circulation. If your compound is cleared at the same rate as liver blood flow, your bioavailability is going to be 0 or really low. But early on in drug discovery and development, if you have an idea of what your steady-state plasma concentration is that you need, and you can actually set this to be your IC50 as just a place to start to look at different compounds. What is the concentration that you want to target? What is your clearance value? And you can have either a clearance value from in vivo data, or you could have a scaled clearance value from microsomal stability. Take these two, multiply them together, and get a really rough estimate of what a dose might be for the target for the compound that you have. We do this on large libraries of compounds when we just have in vitro potency and in vitro microsomal stability values. You multiply these together. When this number comes out 5 grams per day, you need a better compound. There are many things that contribute to what we are measuring in a pharmacokinetic study, which is just total plasma clearance. You might have clearance from in the bile, renal clearance, hepatic clearance. Hepatic clearance is the largest contributor to the systemic clearance. So think about that as you're trying to look at, does my measured clearance match to my microsomal stability scaled clearance? If those things don't match, then perhaps your compound is cleared more by renal clearance or biliary clearance. So coming back to pharmacokinetics, everything is integrated together. Here are 3 compounds, all dosed at 5 milligrams per kilo. They all have the same clearance value, but they have very different volumes of distribution. The compound in red has a very low volume of distribution and a very short half-life. As the volume of distribution increases, the concentrations decrease, and so the blue compound has a moderate volume of distribution, the green compound has a higher volume of distribution. But as the volume of distribution increased, so did the half-life. So the question that you need to ask is, what plasma concentration profile do I need for efficacy? Do I need a profile like this, where I maintain concentrations nice and constant over a long period of time? Is that what's needed for my target? Or do I need to hit with a really high concentration and have it rapidly cleared? Come back to understanding your target and what is the pharmacokinetic profile that you need to achieve the efficacy. So I have 2 examples of pharmacokinetic studies. These were both done in rats, I think. And this might be something that you are given if you ask somebody to run a pharmacokinetic study for you. Typically, what you'll get is a concentration time profile and a summary of the pharmacokinetic data. One of the first things that I look at is the graph. I like to see what the concentration time curves look like, but the other thing I look at is most of the graphics programs, at least our graphics program, automatically cuts off when it doesn't have any more measured concentrations. But I know there was at least 24 hours of time points in this study. So if there are no more concentrations, that means that this compound is being cleared very fast. There were no measured concentrations in the rest of the time points. So if I come down here and look at the clearance values, that's true. The clearance value is about the same as liver blood flow in a rat, so the compound is being cleared very rapidly. The volume of distribution isn't very high, and the half-life is very short. The half-life is very short after oral dosing, but primarily due to the high clearance, we would guess, the bioavailability is also pretty low. So the compound is being cleared by first-pass metabolism before it has a chance to get into systemic circulation. Here's the second compound that was dosed IV, IP, and oral. The IP curve is very similar to the IV curve, but then there are no concentrations after oral dosing. So what does the IV curve tell us first? The clearance is also high here, but the volume of distribution is much higher. Remember that clearance is the clearance of the compound from the bloodstream. So maybe it's being metabolized, but maybe it's also being distributed. And because the volume of distribution is higher, the half-life is also higher. The IP dosing profile looks quite nice, 90% bioavailability after the IP dose, but no oral bioavailability. So why might we not have any oral bioavailability? What do you mean, doesn't?
It can't cross.
Not absorbed? Not absorbed. Good thing. What else? Sorry? It's not first pass. We'll come back to that. Could be degraded. What else? Not so much protein in the GI tract. That's probably not going to keep it from being absorbed. Not first pass. We'll come back to that. Maybe. One more. What if it's not soluble? Didn't get dissolved, wasn't in solution, couldn't be absorbed. That's different than not being permeable. Okay? And so, coming back to why isn't it first pass metabolism? The IP dose also is cleared through the portal vein. And so, because its concentration is very similar to IV, it's probably not first pass metabolism. But it might be permeability, might be solubility. These are assays that can be run on a higher throughput scale than running PK studies. Go back and run some more in vitro assays, learn how that affects the SAR of your compound, and then try the PK again and see if that improves the oral bioavailability. Help define what is the factor contributing to this poor oral bioavailability. So I went to our clinical pharmacology colleagues and said, okay, please define for me a perfect PK compound with perfect PK in the clinic. And they, of course, had this nice laundry list: long half-life, linear PK, double the dose, get double the concentrations, low variability, high bioavailability, no food effect, predictable age effects, gender effects, minimal drug interactions, low and moderate protein binding. And I said, okay, fine, this is a lovely list. But the question is, how many of these things can we start to optimize when we only have rat PK, which is all we're going to have very early in drug discovery? So we mentioned that the half-life was different across species, but if we wanted a compound that had a higher probability of having a long half-life in humans, we'd like to have the half-life in rat be more than 3 hours. We can certainly look at the linearity. We can look at the variability in a rat PK study. We can assess the bioavailability. We can't look at the food effect. Rats eat whenever they want, no matter how you try. The age effect and the gender effect and the disease effects in rats are not similar to humans, so this is not easy to predict from rats. We can't do a good job on drug-drug interactions. We can measure the protein binding, but we can also, from the rats, start to get an integration of what concentrations do we need for efficacy. Yeah.
Are rats generally preferred to mice?
I'm just choosing rats. In the last few years, it's gotten easier to run mouse PK studies with microsampling and very sensitive mass specs. But 10 years ago, it used to be that you had to have only one sample per mouse. And so it took the same amount of compound to run a mouse PK study as to run a rat PK study, and about 50 mice, as opposed to 6 rats. And so we tend to screen in rats, although that's moving to mice. Yeah.
But sometimes compound can be toxic in rats, but not in mice. So, so we just have to be careful.
Yeah.
You can test a compound, it's safe in mouse model, but it can be toxic in rats model.
Yeah, so, yeah, that's true. And there'll be a discussion about tox and picking species later in the week. But the other thing to remember is that PK studies are typically done at relatively low doses. You hope not to have overt toxicity in a PK study. Sometimes we find that with new chemical series. But typically 1 milligram per kilo, 2 milligram per kilo is where you might run a PK study. So you can see it doesn't take a lot of compound. The last couple slides, what I'd like to do is just show you some other things that contribute to pharmacokinetics, things that at some point in time you'll have to ask the question and pay attention to. As you move a compound into development, your colleagues in tox are going to ask you what formulation should they use for the tox studies. And so it's useful to understand how the formulation affects the pharmacokinetics. This is an example where a simple aqueous suspension gave us, or this is actually a capsule or suspension, gave us really low bioavailability. A solution was better, but a lipid solution was even better. Lipid formulations help keep insoluble compounds in solution and help them be absorbed for longer periods of time. You have to trade that off with lipid formulations, which ones are going to be safe in tox studies, but it's a useful thing to understand. This also helps our colleagues that have been charged with making the formulation for the clinical trials. What did we learn in the animal studies, and how does that impact how they're going to go about developing the first capsule or the first tablet? It's also quite possible to have food effects. The food effect may be related to the physical-chemical properties of the compound. The example in the top is a lipophilic compound that has poor solubility, but when it was dosed with food, we got about a 5-fold increase in the AUC. Maybe this can be overcome with formulation, but at least with this formulation, there was a large food effect. The second example here is a compound that at the pH of fed dogs, the pH of the stomach and the intestine changes as the food effect, as when you eat or not, and that is changing the ionization of this compound, such that in the presence of food, the compound became ionized and wasn't able to be absorbed anymore. Pharmacokinetic linearity I mentioned before. At low doses, you often see doubling of the exposure when you double the dose. But as you go up in dose, as you try to ask the question about where do I see toxicity, you're going to hit a point of saturation. And see, here we have increases in concentration to a point where all the concentrations are essentially the same. And you see that in both the area under the curve and the Cmax. This is useful information to tell your tox colleagues, because there's no point in running a tox study at 300 milligrams per kilogram if the exposure is the same as 100 milligrams per kilo. And the people making the compound for you will be very happy they don't have to make so much. This was a compound that we just, for curiosity, dosed in rats that we had put on a high-fat diet, just to see, this is HF, just to see if that would improve the bioavailability. Yes, it did improve the bioavailability, but after 2 weeks on the high-fat diet, they all had metabolic syndrome too. So that contributed to, no, we can't do this for a tox study. The high-fat diet was 50% fat. Another question that we want to ask is, what is the pharmacokinetics with multiple dosing? Are the concentrations at the end of the dosing period, and maybe that's 2 weeks or 6 months, are they going to be the same as when we started? In this example, the repeat dose are all the lighter bars, and you can see that the lighter bars are very similar to what we saw at the beginning of the study. But this also showed us that in rats, the exposure in females was very much higher than the exposure in males. This is something that we see frequently in rats. It doesn't translate to people and is a function of rats maturing at different rates. So if you have an immature rat, the males are going to mature faster and have higher metabolic capacity, therefore metabolizing the compound faster and giving you lower exposures. Females mature slower, and so you have more parent drug. This is something just to define and understand. The second example here is in dogs, where on the first day of dosing, we had a nice dose response. But after repeat dosing, the exposures were very similar and substantially lower. This is something called metabolic induction, where the liver ramps up the rate that it's going to metabolize the compound. And it makes it really hard to maintain exposures with time. Something you want to pay attention to because you might have efficacy at the beginning of your study, but then it goes away. One more thing to pay attention to is metabolites. And does the metabolite profile match what you think is going to happen in man? This is one compound dosed in both rats and dogs where we measured several different metabolites. In the dogs, parent compound is the major species in circulation with lower concentrations of the metabolites. In rats, metabolite 1 has actually higher concentrations than parent. And so the question that you would ask our toxicologist colleagues is rat the right species? Do we want to use rats? What happens in mice, for example? Because what we really want to assess is the tox profile of the parent compound and the metabolites that we think are going to be in humans, not necessarily the metabolites that are in rats. So this is just a summary of the ADME profiles that as you move forward into development, there'll be an expectation that you understand and can define many of these properties. You don't have to know everything all at once. But to get to an IND, we're going to want to understand the permeability, the pharmacokinetics in several species. We're going to want to understand the protein binding. Placental and lacteal transfer is a study that is done later in clinical development. We're going to want to understand the metabolic stability because this goes into predicting the human pharmacokinetics and also help select the tox species. We want to understand how the compound is metabolized. We want to look across species, as I just showed the example, across species at the different metabolites to see which ones are going to be more predictive of humans. We're going to want to understand how a compound is cleared. We're also, from a safety point of view, going to want to understand potential drug-drug interactions. Is the compound going to be a victim of some other CYP inhibitor that you co-dose with it? Or is it going to impact the metabolism of other compounds that it might be co-dosed with? Here's a couple of references. This is actually a very nice 30-page book that summarizes pharmacokinetics. If you want all the equations that are behind it, then get this larger book. This is just another version of the drug development pathway, going from a target through hit to leads, through preclinical development into the clinic, and all the different drug metabolism-related studies that might be done all through the drug development path. And the last two slides I have are just facts. This is an example of why oral bioavailability is difficult, because as a compound goes down the intestinal tract, the time that it spends there is different. The pH is very different. The surface area is very different, and the permeability is decreasing as you go down the intestine. So what you have to do is define or design a compound that theoretically is at a neutral molecule at these pHs. Ideally, you would like it has a higher probability of being absorbed, where in the upper intestine, where there's a higher surface area and better permeability. But there's a lot of variables here. And you can see as you change one of them, it's going to impact others. The last slide is just a further repeat on species differences. I talked a lot about liver blood flow. Liver blood flow is very different across species. And you see, this is what you'll have to understand as you compare your clearance values to understand whether you have a high clearance compound or a low clearance. When we start to do human pharmacokinetic predictions, one of the corrections that we often use is the brain weight of the animals. We also use the animal weight. But you can see there's a very large difference as we're taking animal data and trying to extrapolate to humans and do the human pharmacokinetic predictions. But that's a whole nother story. That's all. Thank you.
Any additional questions?
I have multiple questions. The first one is when you start to do pharmacodynamics, you should do it in sick animals or in non-sick animals. That's the first one. And then another tricky question for me is how do you select the first dose that you want to try in animals? Because you have a lot of lovely data about distribution, etc. But how do you pick a first dose that you want to see efficacy but not toxicity?
Okay. Good questions. So for me, I would do pharmacokinetics first in non-sick animals. Also because it's probably taken you weeks or months to get your sick animal model up and running. Make sure you know the pharmacokinetics before you put it in those animals. So take a parallel set of healthy animals, learn the pharmacokinetics. And when you learn the pharmacokinetics, that also helps you pick a dose that you're going to put into your more expensive animal model where you want to see the response. If you have the pharmacokinetics, you can also then take the plasma concentrations and compare them to the target concentrations that you think you need based on the potency against the receptor, corrected for protein binding. Make an assumption of linearity because you're not going to run the PK studies at many doses before you go into your animal models. We use a relatively low dose for PK studies because it doesn't take much effort to make 5 or 10 milligrams of compound to run a PK study, where it will take more compound to run in your efficacy study at potentially higher doses for multiple days. Does that make sense? Okay.
Keenan, in the course of your presentation, you had an item called time invariant pharmacokinetics. To what extent do biological rhythms, such as diurnal, circadian, and infradian rhythms, have on pharmacokinetic parameters?
What we've seen is that there's an occasional compound where you have diurnal variation. And you see that mostly in compounds where you have to dose BID, and you actually profile the compounds after the first dose or after the second dose, and you see a difference. But I don't think we've ever actually looked very much at diurnal variation in animals. You just make an assumption that it's okay. Yeah.
1 second.
You spoke a little bit about species differentiation and how, so when in our work we look a lot at, different species types, especially early on for like HLM, RLM, that type of thing. And so specifically for me, what we're seeing is we have large differences between, mouse and rat. And so is that an indication for you to be like, okay, if it's having a longer half-life in rat, I should choose that for my PK model? Or is there other aspects that you need to look at as well?
So my first question to you would be, what species are you using for your efficacy model?
It can go either or, that's the thing.
Okay.
So then there you go.
So if it can go either or, then I would come to what can you learn with the least amount of compound so that you can look at more compounds.
And that's where rat is more expensive, right? If you have to make more compounds.
If you have people who can take serial samples out of a mouse, and have the appropriate analytical techniques that you can measure from 20 microliters of plasma or 2 microliters of plasma.
Yeah.
If you don't have that analytical capacity, then I would vote for rats because you can get more samples, larger volume of samples from the rat.
Yeah. Thank you.
Sure.
Any additional questions? Okay.
Thanks.